Hi, everyone. We're back with another episode of Fertility Docs Uncensored. I'm one of your hosts, Dr. Abby Eblen from Nashville Fertility Center. And today I am joined by my unconventional and upbeat co host, Dr. Susan Hudson from Texas Fertility Center,
Hello.
and Dr. Carrie Bedient from the Fertility Center of Las Vegas.
Hi guys. How's it
Hey, how
going?
are you guys doing?
Doing good. Doing
Good.
good.
It's hot as balls here, but good.
So what do you do at your house, Carrie, when it's hot as balls? Do you go outside? What do you do?
I mean, it's torn between staying the hell inside, and going swimming. We spend a decent amount of time in the pool,
Oh,
except
good.
I've
Okay.
lost enough weight recently that I had to order like new swimsuits and like general new summer
Oh,
clothes.
that's a pretty awesome reason to order new clothes, right?
It is, and it was fantastic. Except, so I took all my measurements and I read all the reviews online, and I had some gift certificates that I've been hoarding for the better part of 4 years now. That I'm like, okay, I'm just going to spend them, and so I did, and I got all this stuff in, and I
Were they
tried to do them,
clothes or bathing suits or both?
all of it, all of it. I mean, even
Oh,
shoes and all of it. And I think I kept maybe three pieces total out of the 800 zillion that I ordered because nothing fit. Like it was all too tight, too loose, too weird, too whatever.
Jeff Bezos is going to mark you off the Amazon list, Carrie, if you keep returning all that stuff. He's going to come after you.
I'm a little worried about that. Although for the most part, it wasn't Amazon. It was from the stores that I know that
Oh,
I really like
yeah,
Yeah.
yeah,
and had a higher chance of success. But
yeah.
even then, biffed it.
And
Totally biffed it.
that sometimes happens. Like I order a lot of stuff from Banana Republic because I like the way it fits on me.
Uh,
Exactly that type of thing. But like I definitely don't order this stuff that's not returnable because I'm like, number one, if it's gotten to the clearance section
Yeah,
enough
there's a
that it's
reason.
non-returnable, that means it doesn't look good on some people.
yeah.
Yeah.
Which means it's probably not going to look good on me. And so, you just don't ever know until you try it on. I mean,
I know
it's close to the so hard.
blue jeans and bathing suits, I think, are the two worst. I never
Oh
would
my
buy one of those
goodness.
online because blue jeans, unless you know the brand and you know it fits you well, you never know how it's going to fit you.
I do that
Bathing
for
suits
Banana
are the
Republic stuff.
worst.
I can return them. I can put them on and be like, nope.
Yeah, no, 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 no. Bathing
Yeah.
suits are the worst. Even you're like, okay, I should look good in this. It's got all the things that I think I need and all the places, but then you try it on, you're like, oh my gosh, this looks awful.
So I ordered three bathing suits from this place and got them all in. They're all the same size. They're all like the measurements, all of it on paper worked. And one of them works really well. And the other two, I swear, they forget that women have boobs. And like if you've got the measurements that I do in the rest of your body, you're not going to have tiny measurements on the top of your body
Yeah,
either.
You
And
know,
yeah.
that's
so,
really interesting for those of us who are not well endowed on top. Like buying bathing suits is always it's funny because like when it comes to, I usually wear two pieces, but sometimes I have a little bikini top, but a lot of times it's the little tankinis and stuff. But trying to find ones that are like in smaller sizes and not for people who are ginormous is an act of Congress. Maybe it's just everything's in the middle and those of us on the extremes are just SOL.
maybe, I
Yeah,
mean,
and
I tried
see,
on one and I'm like, oh, hey, look, I could join OnlyFans with this one. Um, yeah, it was indecent is the lightest adjective that you could have come up with that. And I was
yeah.
showing my family and eyes were like, yeah,
See,
eyes were wide and
my coverage complaint is the butt, not the top, but the bottom. I have too big of a butt for the slimness of the suit, and I feel like I'm showing my butt too much.
At Target, they have like different I just went to Target today and looked at the swimsuits and they have pictures of butts. So it tells you
Ah,
like how much coverage and the least amount of coverage was extra cheeky.
no
that
extra.
is
Mine's
I
always
No
did
extra
see
extra
a lot of
cheeky for me.
I did see a lot of cheeky description. Although they don't have anything like there's no boob coverage description of like
Mm.
boobtastic, extra boob, extra whatever. And I feel
Tiny
like
bit
they
of
need
boob
to come up
covered,
with that.
large amount of boob covered.
Anyway, I'm sure we have some professional things to discuss today. What
We
questions do
do.
we have?
Actually, now that you mentioned it, Carrie, we're going to do a question episode and we're going to talk about testing. So, testing
Oh,
for all different things related to infertility. So,
yeah.
Susan, take it away.
I have to say, I just want to make a moment and like say I love doing our question episodes because we were able to dive down like little bitty rabbit holes at a time that we couldn't do on a full episode on
Yeah,
something.
that's
And so
true.
I, especially on testing, because there's little things that we don't necessarily discuss. And so this way we kind of get into some of those caveats. So, all right. So our first one is, would you recommend that a heterosexual couple with unexplained infertility who have normal results from their initial workup continue running other tests to understand the underlying issue for the fertility issues before jumping into fertility treatments? Some tests and questions are Receptiva, SpermQT, Dutch, etc.
I mean,
That's
it
a
kind of depends.
really good question.
Yeah, it kind of depends on what they've done. And, there's not like every doctor in the United States that does what we do doesn't do exactly the same test. So it kind of depends on what tests you've had done. But what I always tell my patients is there's a reasonable chance that we may do all the tests that I think are reasonable, and we may come up with no answer as to why you're not getting pregnant. And the reason is there's so many different things that have to happen for an egg and a sperm to go together. And so, I think the basic tests we would all agree on, like check the tubes, check the uterus, check the sperm, make sure there's a good egg number. There's some other sort of side tests like thyroid condition we want to check, and things like that. But there's some other side tests which we may want to go into, but those are kind of the basic ones. And then there are some other tests that we can do, but just because we don't know why you're not getting pregnant doesn't mean we can't help you get pregnant. So there's no reason you shouldn't go ahead and start on some sort of treatment, because we've hit the big things. The other things are kind of minor, less cut and dried things. And so my vote would be, if the basic things are negative, it's frustrating, but I would say proceed on and head toward trying to get pregnant, because that's why you're going to your doctor.
What are your
So
thoughts, Carrie?
there is a subset of patients, and this is entirely profiling, but if I see that you're an engineer or
Yes, an
if you're
accountant.
an accountant, there are very certain data-driven professions
Yes.
that I will say specifically upfront, we're going to do all this testing and we are going to get whatever results we're going to get. And if everything comes back normal, I need you to know that there is 15% of patients that have unexplained infertility, because that means that the testing didn't show anything. It doesn't mean that you don't have infertility, because even if the testing's normal, you know full well from practical experience you're not getting pregnant. But this is an entity of itself. People write papers on this specifically. There are treatment protocols for this specifically. And so I just want to let you know right up front that that's a thing. And so there are some tests that we can go above and beyond, but a lot of times those things are not going to change what we do and how we do it. And so if you need to know and you don't mind running the tests, the financial, the emotional, the physical, all of that, sure, we can run them, but it won't necessarily add to anything except taking more time and more resources. And you only have so
More
much
money.
capital. And so just, there's a fine line between getting the things you need and getting the things that you think you need.
So I would like to add something. So they mentioned SpermQT, and this I think is one of the newer tests that I think actually uncovers some things that
I
were
think so too. Yeah.
unexplained fertility that we now have an explanation for. I don't want to go down the rabbit hole of talking about everything about SpermQT, but that was on episode number
184.
184. So you can listen to a whole episode about that. But if you have unexplained infertility and you have done nothing, that's actually a group of people that I think doing SpermQT is very helpful for, because it will help you figure out how aggressive or not aggressive you need to be. Or if you have unexplained infertility, you've done about 3 cycles and you really, really, really want to avoid IVF at almost all costs, doing that SpermQT is really going to help you potentially figure out if maybe doing a couple more cycles might be helpful, or if you're just spending money doing more cycles. So, I do agree totally with what Abby says. There has to be a point that you understand that even though we may not have an exact answer, our treatments for unexplained infertility are efficacious. Okay. And you just have to kind of jump in and start doing it. And sometimes you can do some additional testing while you're doing treatments too, if that's kind of the direction you want to go in.
Yeah. it's doing all those extra things may or may not actually be of use. And there's only so many things that we actually can do in response. So some of the tests, you know, if you want to do a Receptiva, for example, it's great. But if you know you're only going to do IUIs, the Receptiva may not be a whole lot more helpful for you. And so it's really useful for IVF in some cases, but not for every type of treatment. So what you think you want to do treatment wise will also impact that.
Good stuff. All right, here's our next one. Hi, ladies. Love listening to your podcast. It's been so helpful. I have endometriosis that was diagnosed a little over a year ago via laparoscopic surgery. Been trying for 2 years, 3 chemical miscarriages, and haven't had any luck with medicated cycles. I'm meeting with my OB-GYN next week to discuss next steps and start a referral process to a fertility clinic. My question is, my husband has a medical phobia. He's not afraid of needles or blood draws. It's the results that terrify him. I know going to IVF will be both get blood panels and recessive traits. How can I help calm his nerves? Have you ever experienced this with patients or their partners, and how did you address this? Thank you so much. I love this question.
All right. So Susan, how would you answer this question?
Yeah.
So what I would do is and I'm assuming it's mainly the tests regarding him that he's super nervous about, but you can do this with yours. But sitting down and first of all, explaining that to your physician that he has this phobia about having the knowledge. And we as physicians can sit down and talk about, okay, for this test, this is how you get power in the knowledge. And here are how it helps you in your decision making. And if you lay out information as it is parts of the puzzle, and it's how we're going to put the whole puzzle together to be able to figure out what's going to be the best treatment plan for the two of you, I think it breaks it down. It's not just information, because it's not that he's scared of getting information. He's scared of what that information means. I'm a strategic thinker. If you ask me a question and you're like, can we do this? My first reaction to almost anything is going to be no. You can ask my husband, because when you ask me
you can also ask her podcasting partners that.
Yeah. We're kind of like her podcasting wives, I think.
My podcasting wives here, in that when you suggest something to me, like I see all the things that are going to happen, and some of them are good and some of them are bad, and it's my defense mechanism. But once I'm able to sort through it, then I'm like, okay, and I usually come to a balanced, well-rounded, and reasonable decision. And so that's how I would deal with it.
See, the way I look at it is, I think, and I don't know this man, but I think he's, like you said, fearful of the information that he's going to get. So basically, he's driven more by fear. He wants to have the knowledge, but he's afraid of what's going to happen when he gets the knowledge. So a lot of times, and usually for men, number one on the list is my sperm going to be really low, or is there going to be a problem there? So I usually start out by saying, you know, if we get your sperm count and it's abnormal, doesn't mean it's going to stay that way permanently. There's reproductive urologists that we can send you to. Sometimes they can put you on medications. They'll do testing to see if they can get to the bottom of it, see if we can fix it. Even if the count's real low, if we can get it up to a little bit higher, there's some things in the office we can do that won't cost you a bunch of money, because I think fear is driven also by the finances as well. And, you know, if you're worried that you won't have any sperm at all, if you have literally, if she has 10 eggs, if we do have to do in vitro fertilization because your count's so low, literally she has 10 eggs, you need 10 sperm. So the bar is really, really low. And so that's kind of the way I approach it. I kind of try and tell them why it's beneficial and that there are some things we can do. It's not like the end of the road. Like, it's not like you're never going to be a father if you don't have sperm or if your count's really low.
One thing to consider is that for some of the ones like the genetic testing in particular, when you're getting carrier screening, where it's not just your results that matter, it's your partner's results as well. That's something where it may be helpful to have your partner get their results started a week before, so that by the time you get yours, the other part of that information is in, because getting your own results back and finding that you carry 5 things is very different when you already know your partner doesn't carry those 5 things, because it immediately takes the results from a place of high anxiety down into, all right, moving on. And so that's something to consider as well. I also highly recommend therapy for virtually everybody who walks through our doors. Like, if I could figure out a way to legitimately get a counselor under our office to have just around to see every single patient and available for every single patient, I would do that. So for our counselors, if you know how to make this pay for itself so that it just like gets covered by insurance, I would love to hear how you would do this.
Yeah.
But I really recommend it to a lot of people, especially when there's any medical anxiety, because there will be a lot of medical anxiety, not just with this, but once the person is pregnant, once you have a child, like it's not like this anxiety goes away when you have a
Right. It
small
just
human
only
being
continues.
that you are now 100% responsible for their continued existence and well-being. Like this anxiety doesn't go away, guys. And so ever, yeah, like the whole, oh, I just have to for the next 18 years. Screw that. They're going to be alive ideally much longer than that, and you're going to worry about them forever. So just start the good management of it now. And whether it's a therapist, a religious person, your best friend who should have been a therapist, whatever, tap into that because it will be helpful because none of this is going to fade quickly.
Totally agree. Good stuff. All right, our next one. Hi, docs. I'm 35 with a history of subclinical hypothyroidism that's never been treated. TSH was elevated at 5.69 in 2014 when she was 25. Since then, it's mostly been in the 3 to 3.5 range. Last month, it was up to 4.53. Reference range at the doctor's clinic is up to 4.2. Blood work has been negative for TPO antibodies. My question is, since my husband and I are planning to start to try to conceive in a few months, should I push for treatment to get my TSH lower? Should I be concerned about the risks of miscarriage and/or fertility issues, or just hold off on treatment and wait to see what happens?
What
Wait,
was
so
her most recent? Yeah.
that's my
Most recent,
exact question. What's the most recent?
4.53.
Oh, yeah.
4.53?
I mean,
I
for
would
her,
treat.
I would treat that. Yeah. For her
Yeah.
partner, that may be okay. But for her, it really, most of us want your TSH to be 2.5 or less. I'm glad you don't have thyroid antibodies, but still, we want your metabolism running a little bit faster. And actually, the American Society for, the American College of OBGYN and also the Society for Endocrinologists basically agree that there should be a different norm for somebody that's either pregnant or trying to get pregnant. So I think about any of us would agree you need to be treated.
Mm-hmm. There's more wiggle room if you're between like 2.5 and 4, especially without antibodies for not treating, especially without some other history of pregnancy loss or other things like that. But yeah, once you're over 4, it starts to get a little bit clearer of just start 25 of levothyroxine. Like it's just wave it under your nose, it'll be fine.
The other thing to know is about thyroid hormone is that the need for thyroid hormone, especially in the first trimester of pregnancy, but throughout all of pregnancy, it's a moving target. And
Yeah.
your requirement is going to greatly increase. And we don't know if how steep that increase is going to be for you. And so if you're at 4.5 right now, you get pregnant, you might be at 8, which of
Yes,
course we're
that's,
going to have you on thyroid hormone. So
yeah.
it's easier if we're a little ahead of the game on that. So
Mm-hmm.
Yeah, and that's happened at least a couple of times with me with the patient you check and you're like, and then they get pregnant and then boom, you're like, oh my gosh, we got to bump them up fast. So it's better to get ahead of the game.
occasionally we have people who it's been like stone cold normal and then they come up pregnant and it's like sky high and I go,
Yeah,
look, I'm like, did I miss something? And it's like,
I
no, this
know.
happens.
Yeah.
All right, our next one. Hi, thank you so much for the great information you provide in a fun way on your podcast. Thank you so much for listening.
Yeah.
I've learned so much. I am wondering if a day 21 progesterone level of 8 is or is not favorable for implantation and pregnancy in an IUI cycle. I had the level drawn in the afternoon and have read that the levels are the highest in the morning, but that 10 or more may correlate better with pregnancy outcomes. Is there anything I can do to boost my levels? Appreciate your insight. Ooh, the progesterone level, the dreaded
Yeah,
question.
the paper that was first written, and I was trying to remember when that would have been. That was probably like 20 years ago or something. Basically, they had people come in and they looked at progesterone at 3 different times in the luteal phase, and they averaged the number together. And that's just because there's so much variability. So we've really kind of over the past several years have really scrunched it down to where we check it one time and we say, oh, that's it. But we all know that there's variation in blood levels at different times during the day and different times in the cycle. And so that's just kind of a guess. I mean, typically I like to see it over 10. And so, but typically I think checking it more than if you really are worried, check it 3 or 4 times and average the number because you can't, it's like hitting a moving target when you try and do it one time.
Mm-hmm. I think so some of this depends on exactly what type of cycle and what your doc is doing, because sometimes by that point in the cycle, you may not have actually started the progesterone supplementation that your doc has ordered, or some docs don't do it until you actually have a positive pregnancy test. Like a level of 8 is a very respectable level. It shows that you ovulated. It shows that your levels are much higher than they are normally. When we check on day 3, the level is usually like well under 0.5, certainly under 1. And so some of this depends on what the big picture is, because there's not necessarily additional benefit at that stage in an IUI and slamming yourself with progesterone, or by setting too much stock in it. Because if you ovulated maybe a day or two later than you think you did, that's going to really skew how you interpret those results. And so I would say a level of 8 is a very respectable level, and that's about the level of information you can expect to get from that one isolated hormone level.
Yeah, I think an important thing to understand is the difference between a cycle day 21 progesterone level, that its true value is to prove whether you ovulated or not. And I think we all sit here and we're like, 8, you ovulated, no doubt about that. Okay. The other thing I'd like to mention is people will, not on supplementation, will have a negative pregnancy test, and they're like, what did you think about my progesterone? Well, in light of a negative negative pregnancy test, your progesterone level is inconsequential. Like it's usually low if you weren't on supplementation and you have a negative pregnancy test. So, sometimes people come in, they're like, oh, my progesterone level is low every time they do a pregnancy test. Well, that's because it's been negative. Okay. Now, if it's a positive pregnancy test and you've had lower numbers, that's a different conversation. But just understand that progesterone truly is a moving target. And so we have to understand where it is in the cycle to make sure it's interpreted correctly. All right. Our next one. It seems to be common practice at my RA's office not to offer pain management for procedures like HSG, saline ultrasound, and Receptiva. Is that typical? The infertility journey is already so emotionally painful. Why not try to manage and reduce the physical pain? I'm curious. Is my RA an outlier? Do other RAs address pain management? I know there are major gender disparities in the way female versus male pain is managed. I can't help but thinking men were getting biopsied of their internal organs, they would be offered something more than take 2 ibuprofen. What are your thoughts?
Well, I would say there's a huge drug epidemic in the United States, and a huge push over the past, I don't know, 5 to 7 years has been exactly what you're saying. Don't prescribe narcotics. And a good example for us is when we did egg retrievals, probably about 4 or 5 years ago, we would give Percocet to every single person that had an egg retrieval. And the reality of it was the majority of people didn't even really need the Percocet. And so there have been studies that have shown if you give a patient ibuprofen and Tylenol together, that they work better than either one of them separately. So for many of our biopsies and things that we do, that's what we do now. And that's really been a big push by the government and just by the society in general, because so many people can iatrogenically, meaning they can get medicines from doctors for a legitimate reason. And then that's the thing that tips off their addiction. And not necessarily just for, an office procedure, but like narcotics, say for a surgery or something like that. There's data that's shown the longer that patients have narcotics, the more and more likely they are to become chronically addicted. And so there's been a huge push in the medical community to really back off on giving narcotics for really anything, and particularly for outpatient procedures in the office. So I think most of us have kind of followed suit in that regard. I think there's some situations for patients, if they really are nervous and really feel like they're going to need pain medicine, I'm not going to go, no, I'm not going to give you pain medicine, but I don't routinely offer it unless somebody really asks for it.
I would agree for all of the reasons that Abby just mentioned. I mean, we've all had people that we've known who have died from the drug epidemic, and it starts with us. And it sounds like a little thing. It's like, oh, well, I just need a few for this and a few for this and a few for this. But unfortunately, there are certain people whose brain chemistry, that few can be all that they need to go down a path that none of us want them to go down. So, if you're somebody who has, and a lot of people have varying pain tolerances. So if you're somebody who has a low pain tolerance and you need something, and there's also the issue of like, if you take any of the things that are really going to be quote stronger, you're going to have a driver. You're going to have to be out of work for that day. These are big controlled substances, and so we have to be judicious in how we allocate those.
When a lot of times when you're thinking of some of the pain that happens with this, a lot of the pain that is caused is actually anxiety. And it's the anticipation of, I am going to have something done to me that is painful, that heightens the experience of pain. And so, because part of pain is the physical component to it, the other part is the mental response to it. And so, nobody is saying that the stuff that we do is not painful, because in many respects it is. I mean, at best it's uncomfortable. And so sometimes it's dealing with the anxiety ahead of time. Sometimes it's giving a one-time medication of anxiety medication to help relax somebody as they're going into it. There are patients who I have with really significant concerns about pain, and usually truly it is the anxiety more than the actual pain that they're going to experience, where there will be some of these things where I will put them out and we will do full anesthesia, especially the Receptiva biopsy, because I'll combine it with a couple other things and just do it all at once. And you're not going to get addicted to the propofol that we give. It's not an addictive substance. It burns through your system super fast, so it's there long enough for me to get the information that we all need and then get out. It does add expense. It does add time. It does add the need for a driver and a need for extra nursing care, on the part of the office, extra resources, things like that. So we don't want to do it if we don't have to. But for the patients who I know full well, there is absolutely no way they're going to tolerate this. Then sure, we'll knock them out for the 5 minutes that it takes. It's just, there's so much extra involved in that we don't make that a routine. And frankly, if we did make it a routine, there would be a whole set of patients who objected to having to be put out for a procedure to do that. And so a lot of what we do is just a balance of, how do we get the information we need to help you while not torturing you in the process? Because none of us went to school for that. It's knowing what's real, what's anxiety. Not that anxiety is not real, but it flavors it differently. And how do we best manage whatever your situation is to get you where you need to be?
Absolutely. Good stuff. All right. Our next one. Thank you, ladies, for your wonderful podcast. I discovered it a few months ago and have binged every single episode. That's awesome. I've learned so.
Wow.
I'm 42, controlled diabetic, A1C of 5.7, controlled hypertension, overweight. Labs are normal, no diagnosed fertility concerns. Myomectomy in 2018, HSG and saline ultrasound done in the past year, both normal. Over the past 4 years, 8 IUIs. One ended in miscarriage at 7 weeks at age 41. AMH was 1.39 then. Switched to IVF at a different clinic using donor eggs in January with donor sperm after learning how genetically abnormal my eggs are at my age. First 2 FETs failed. Clinic suggests Emma, Alice, and ERA testing. I've heard you talk a lot about ERA, but can you speak as to the benefits of Emma and Alice testing? Thank you. So I'll take this one to start with. Emma and Alice are really looking at good bacteria and bad bacteria. Okay. There are not a lot of tests out there looking at the good bacteria, but my recommendation is, if you're wanting good bacteria, use a good probiotic prophylactically. It hurts a lot less than having an endometrial biopsy done. And when it comes to bad bacteria, I mean, the test is a good test. And what I tend to like about the test is it does give sensitivities for the specific organism it detects, which not all tests looking for chronic endometritis do. But it's one of many choices. So that's what I would comment on those two.
Yeah, and I think at 42, I mean, the bigger issue is, I think, kind of what we said, alluded to in an earlier question. You know, this is something you can do, but is it going to have a dramatic result on your outcome? Probably not.
But
It's
she's already
hard to.
using donor eggs. She's already using donor eggs.
Yeah, and I don't know if she has any more left, but yeah, it's hard to know why your donor eggs didn't work. But I don't know that that's going to be the test that's really. I mean, there's no data that I know of that says that finding that out. Certainly, if you have endometritis, you want to treat it, is going to make a difference. I think if no one has hysteroscoped you at this point, which I bet they probably have, that would be something that would need to be done, and take some biopsies and just see if there's anything going on in your cavity that's causing issues. The
And also,
tricky part. Go
if
ahead.
you haven't had your embryos tested from your donor cycle,
Yes.
like there's a
Yes.
lot of people who have failed FETs, and it's like, well, I did donor, but I didn't do any genetic testing because I didn't think I needed it. But half of those embryos are theoretically abnormal. So that's another piece of the puzzle.
And I don't know if she mentioned Receptiva, if she's done that test or not. Did she mention that?
She had not mentioned that, but that's a good
So
one.
the other potential test, and really this is a discussion I think we probably all three have a lot with our patients, particularly patients who have had even genetically normal embryos transferred and they haven't had good outcomes. Unfortunately, we've really done most of the testing that can be done on the embryo and we do the genetics. The problem is what's going on with the endometrium, and there's just not that many tests to really look at that. I mean, you hit the nail on the head with Allison Emma tries to look at that. The Receptiva assay, which was episode number 171, I think we said,
Yep.
is a really great episode, and you can dive into the depths of that when you listen to that episode. But essentially, it just looks to see if you have an inflammatory marker there that could be a problem. And if you haven't done that test, you may want to consider that as well.
Mm-hmm. Seen and agree with all of the above. I was going to chime in with make sure you get your embryos tested. Susan said that. Abby commented on the Receptiva. So, yep, agree.
All right. Hit all
All
the
right.
spots.
Y'all want to do one more question?
One more. Yep. Sounds good.
All right. I had a recent HSG that suggested a possible unicornate uterus and patent right tube. However, the doctor noted that the right tube, quote, appeared abnormally dilated before the contrast spilled. They recommended a laparoscopy, but the wait list is very long where I live. In the meantime, I'm spending way too much time on Google. I read that there is a frequent false positive rate on tubal abnormalities. If the dye spilled, should that not indicate an open tube? What might the outcome of this laparoscopy be?
So there's two things that you think about with tubes, if not more. One is flat out, is it open? And so when you are looking at an HSG, if you see that the tube is open, that is a reliable finding. It's really hard to get a false result that the tube is open. So that is good. What people refer to when they talk about HSGs not being reliable is that if you see what's called proximal tubal occlusion, meaning the tube is blocked at the entrance to between the uterus and the tube, that can be a false positive, meaning you put the dye in, that's painful, the uterus cramps, it gets pissed off, the dye doesn't flow, and you think you've got a blocked tube, when in reality, you just pissed off your uterus, because anyone who's had an HSG will know this is not a comfortable test. And so that's typically what we refer to when we think of there's a high percentage of false positives on an HSG. That's usually far and away. Now, the second thing to consider is what is the structure of the tube itself? Is it a nice thin spaghetti noodle, or are we talking about like major stuffed noodles, manicotti type, cannelloni or cannoli? That's what I was looking for, not cannelloni. Maybe cannelloni? I don't know. I'm not Anyway, you want to know, do you have a spaghetti noodle? And so if you see that it's nice and thin all the way through, that's really reassuring and reliable. What I have noticed sometimes is that when you push the dye through, think about the cartoons we watched as kids where somebody would stand on the edge of a hose and the other character would turn it up way fast. And all of a sudden you'd see this giant basketball of water moving through the hose, and then it hits the end. Well, that's not how this works. You should have, if it's thick, it should be thick the entire time. If it's thin, it should be thin the entire time. Sometimes what you see is you get a dilation the more you pump that fluid in. And so it makes an otherwise not totally normal, but normal-ish tube might look considerably worse. So the advantage of going in with a laparoscopy is they can take a look at it before anybody has done anything to piss off that tube. Because tubes hold a grudge, right? The uterus can tolerate anything. It can grow a watermelon inside, push it out, do that multiple times. It can have a period and completely regenerate its inside every single month. But the tube, if you so much as look at it cross-eyed, it gets pissed and it doesn't behave normally. And so when you go in with a laparoscopy, you look at it before you've done anything to irritate it and you see, okay, is this swollen at baseline? Because if it is, we know that this is not reliably functioning in the same way that one that looks stone cold normal. They can also take a look at the dye flowing through and see, okay, as soon as we push it through, do we all of a sudden get a big fat sausage of a tube compared to that spaghetti noodle we're looking for?
But one of the things I'd say about the tube is that when you put the dye through, the other possibility is that it can spill out of the tube. But if there's scar tissue around it, like from endometriosis or if bowel is stuck to it, sometimes it looks like it spills, but if you keep pushing the dye, you see that it's loculated, almost like it basically just stays in sort of a place around the tube, kind of like if the tube itself is blocked. So it can be blocked at the end, or it can be kind of basically walled off with bowel or other things in the abdomen. So it's a really good idea. Hopefully your doctor actually looks at the films themselves to really get some sense for what it really looks like. The other comment I would make, you mentioned that you had a unicornate uterus. Well, at least once and maybe twice, I've had patients that thought they had a unicornate uterus, and then they came to see us, and we looked, and we found out that in fact they had a didelphic uterus. In other words, if you have a uterus that looks like a unicornate, really the onus is on your doctor to prove that you don't have a whole nother half of a uterus that just is completely separated. And so that can be done usually by ultrasound. It can be done by exam. Sometimes it's actually kind of hard to see when you're looking with a speculum, but if your doctor does an exam, a bimanual exam where they put the fingers inside, sometimes you can actually feel that second vagina. So sometimes people have two complete separate systems, separate uterus attached to an individual tube, separate cervices, and separate vaginas. And so if you have a unicornate uterus, I just make sure that somebody's done an ultrasound on you and really knows that that's all you have, that you don't have another uterus that's hiding in there too.
And no, if you do have a unicorn uterus, we do need to have evaluation of your urinary system, your kidneys, and your ureters, because they actually develop at the same time. And so you're at a higher risk of having had some developmental abnormalities, which in itself is not usually a big deal, but it's always good to know if, hey, we only have one kidney or we have double collecting systems or something like that. So good information.
Yeah. I
All
like these
right. Well,
episodes. They're very satisfying.
yeah, I think this was a great episode. So, to our audience, thanks for listening. Tune in next week for more. Also, be sure to subscribe and leave us a review in iTunes. We'd love to hear from you.
You can also visit fertilitydocsuncensored.com to submit specific questions you have about infertility. All questions will be answered anonymously on our Ask the Doc segment, so don't hold back. We love episode ideas, so let us know what you're thinking and what you want to hear.
As always, this podcast is intended for entertainment and is not a substitute for medical advice from your own physician. All right, we'll talk to you soon. Bye.
Bye.